for joining us for today's webinar, Tactics for Meaningful Work with Challenging Populations, with presenter Jessica Stewart of Cloud9 Consultant. You all should have received a handout this morning that Jessica will be referencing throughout this session. And this is the third of a three-part webinar series offered by the North Country Care Coordination Workforce Collaborative, or the NCWC, and is geared towards care or case managers and care coordinators. My name is Victoria Kaniram, and I'm the Director of the Health Resources and Services Administration Rural Public Health Workforce Training Network grant out of the Adirondack Health Institute, through which the NCWC was established. And then for those of you not as familiar with the NCWC, it is a regional consortium of employers, providers, education institutions, and other workforce stakeholders established to create and provide care coordination training programs focused on rural healthcare workforce needs within 8 counties in northeastern New York. And today I'm also joined by Kelly Owens, Executive Director of the Hudson Mohawk Area Health Education Center. Kelly and HMAHEC assist with NCWC program planning, development, and technical support. So we are here today to ensure the webinar runs smoothly. And just a few housekeeping items. This webinar is being recorded and will be posted on the Health Workforce Collaborative website under the Care Coordination section, which we will put the URL link in the chat. And then we ask that you remain on mute for the duration of the training. Cameras are optional, and there will be time for Q&A at the end of the presentation. And we encourage you to enter any questions you may have into the chat so we can review that a little later on. And then lastly, we have a brief program evaluation that we will email to all participants, and we'll put a link in the chat at the end of the program. Please take a couple minutes to complete the evaluation. Your input and feedback really does matter. It helps us to determine what to offer next. And then this webinar has been approved for 1 continuing education credit hour for social work, licensed mental health counselors, physical therapy, occupational therapy, and speech language pathology. Certificates of completion are also available. So if you would like CECs or a certificate of completion, please make sure you remain on the training for the full hour. We will be taking attendance as the regulatory bodies that provide CE credits require your full attendance, and participants will receive certificates by email after the evaluation has been submitted and reviewed. So with that, I'm going to turn it over now to Jessica, and we hope you enjoyed today's program.
Thank you so much, Victoria. Welcome to today's training. Today, we will be speaking about tactics for meaningful work with challenging populations. All right, so let's get right into it. Our discussion points today are going to be awareness. Excuse me. Let's see. I apologize. We skipped ahead. There we go. Okay. I can't find. Just one moment, please. There we go. I think because there's such a large amount of people, it is coming up. But that's wonderful. Okay. So our points of discussion today will be about awareness. So we'll identify some factors that contribute to resistance to treatment. We'll also do some basic risk assessment, which is identifying factors that can put a client at risk for suicide, as well as just some very, very brief talking about safety planning, the value of that, and how we can use safety planning to keep our clients safe. All right, so jumping right into it. What we see sometimes is we see this resistant or even refusing treatment. So maybe what we've done is we've done a good job of reaching out, contacting someone, getting them involved in treatment, or maybe even someone kind of came knocking at our door and said, you know, I need some help, or I would appreciate this assistance. So it's appointment time, you know, things are very busy. And then all of a sudden we notice that our client may be ignoring some calls. Maybe they're having no-show appointments. They may even come to session and we notice that they're having yes or no answers only. So we're trying to open up the conversation. We're trying to learn more so that we can assess the situation and really support this individual. But it's very kind of short and cut off, yes, no, not really engaged. We may see constant rescheduling, even lack of motivation. I don't really know why I'm doing this, or I don't really feel like coming, I'm coming late. Sometimes we also see people be sort of rude to us, disrespectful, or take some personal jabs. How long have you been doing this? You're book smart. You're not, you don't have that real life experience that I have. We may start to see these things, and they may start to convey, I don't trust you, or I don't think that this is going to be helpful for me. And a lot of times we have this thought, I thought we agreed. I thought that we kind of had this sort of agreement moving forward that, treatment could, or care could potentially benefit you. So how that impacts us, and let's get real, it does impact us. I think a good saying sometimes is leave work at work, but that's like ideal scenario. Essentially, we want to leave some of our work at work. Of course, we don't want everything to trickle into all areas of our lives, but a lot of times it really does impact us when we have clients that are resisting or refusing treatment. How they can impact us is we may feel like we're not being productive. And also we may get pressure from management that says, hey, you know what? You're not meeting these expectations of your work, of the job. And you're like, well, I'm trying to make these appointments. This individual's not scheduling, or this group of individuals isn't attending. So we may start to feel some pressure. We also may start to get discouraged and say, this population is so difficult to work with. I'm not really seeing how my work is impacting them. It's just such a fight. I feel like I'm doing more than these individuals. It's really, can start to weigh on us. We may also start to get angry, and sometimes that can be a result of missed family time. I'm staying late after work because you missed your session, but then you want to call me at 4:45 and tell me everything that's going on. And it's consistently making me late for certain things, or, I feel like when I get home, I'm exhausted, and I don't have that to contribute to my personal life. And just an overall feeling of increased stress when our clients are resisting or refusing treatment. So we can get this kind of feeling here of like, why do I even bother? Why am I bothering to put so much effort and work into this when it feels like this person is just pushing back against the help that I'm trying to offer? So it's normal. This doesn't make everything feel awesome, but just to let you know that it's normal to feel frustrated, because we do get excited. We can get excited when we say, oh my goodness, this person has come to me, and maybe it's taken them years, maybe it hasn't, but maybe it's taken them a while to kind of open up and even be open to care and treatment with us. And we start to picture, oh, I see the work that we can do. I see how I can facilitate this communication with the family so that there isn't this rift. We start to get energized by this. So it can be a letdown when we start to see that maybe this person won't accomplish their goals. Maybe this person isn't ready at this time. And one of the best things we can do at this time is tell ourselves it's not personal. And it's going to feel personal at times, and it can feel like a letdown, but telling ourselves and reassuring ourselves sometimes that it's not personal, it can help us a little bit, and it can help us grab some distance between the feelings that we're in the moment, and also, just the reality that maybe it's not about us. So, how many people have had this situation? I will be the first to admit I've had this situation, and I literally use this in my head now all the time so that I don't have the situation. But is this person, are they yelling out of the window to ruin your day? Or are they rushing to the birth of their child? So it's about perspective. So sometimes we assume this person's just trying to make me mad. Look at them. They're angry. They probably make so much money. They're driving a nice car. They got the life, and look at, they're still angry. And then, what we don't see is what's going on behind the scenes is maybe this person is a pretty pleasant person, and they just need everyone to get out of the way because they're so excited to get to that hospital and see their baby being born. So there's definitely situations in life that, you know, if we do take a big step back, we can see that there's other options. But it can be important as we move into this discussion about what to do with clients that are maybe a little bit more resistant or challenging or suicidal. What do we do? And are we making assumptions that maybe are not helping the interactions that we're having with this individual, and maybe it's not very supportive of the situation? All right, so gentle reminder that, again, we don't know what's happening inside of people. We can always think of examples where maybe someone has surprised us and said, you know, actually, I'm feeling really down. And we're like, whoa, what? This happens all the time on social media. I can't tell you enough how, you know, how much I've heard this. I actually years ago, I had someone in the military. I was working with the Department of Defense in the military, and a family came to me, and they literally looked like they were out of a magazine. Gorgeous family. And she literally she showed me her phone. And she goes, "Look at this." And I said, "Wow, your family's beautiful." And it was like the Instagram perfect family. And she said, "Yeah." And then she started bawling and just unleashed all the stuff that was going on. And you know, sometimes what happens is we make these assumptions, you know, this person, they're doing fine, everything's fine, but really we don't know what's going on behind the scenes. So I'm sure we can all think of a time where maybe we've showed up with a smile on our face, but really we felt horrible. You know, maybe that day people are saying, "Oh, wow, like you're so peppy," or like you brought sunshine to my day, or, you know, "You look great." And then we're thinking, wow, it took an extra like 15 minutes to get out of bed this morning just because I was just feeling funky and I just wasn't feeling it. So really, as we move through this discussion, just remembering that, you know, sometimes we do make these assumptions. It can be normal to make them, but we really don't know what's going on inside of people. Um, so one of the best things we can do is ask. So let's say we go into work, and this can actually apply to our clients that we're working with. This can also apply to our coworkers too, these things. So what can I do if we know that something's maybe off? You know, maybe I don't suspect, okay, this person's going to kill themselves or something, you know, like that, but maybe I do, or I'm not sure. One of the best things we can do is check in. And I love one and two because really you need two to have an effective one. And what that means is if you're checking in, you really need to be able to listen. So a very common scenario that happens all the time is someone walks by you and they're walking by you and they're like, "Hey, how you doing?" They don't care how you're doing. They're not like, "Hey, how are you doing?" Squared up to you, willing to listen, making eye contact. What they're doing is they're like, "Oh, hey, how you doing?" And it's not really a conversation. They're not really checking in with you. So if you want to effectively check in with someone, ask how they're doing and show that body language that shows that you actually care, that you're listening. So allow time for silence. Allow for time because someone may have to kind of process, how am I going to put this into words? And pauses. So a lot of times we want to fill up the space, especially if it's uncomfortable. I do a ton of grief counseling, and I will say, you know, a very awesome skill is to be able to sit back and to allow for silence and allow for time, because that's where people can really express themselves. Especially someone that might be hurting or in pain, they may be really struggling with how to put it into words. So if we check in with someone and say, "How are you doing?" You know, "Hey, like, how are you doing?" Allow for time, allow for silence, allow for pauses. And that can show the individual that you actually do care and that you're listening. And we do this with our clients sometimes too. "How are you doing?" "Oh, I'm doing well." "Okay. Okay, well, let's get into this." You know, sometimes like if we do add a little bit of space in between, sometimes that person can open up a little bit more. So just a gentle reminder that like these first two steps can be super, super important. And really the rest of the steps are meaningless if you don't initiate the conversation with some genuine concern or genuine care. The next step, number 3, can be super important, especially when working with individuals that we are concerned might be suicidal or might kind of have some dark thoughts going on or be at risk for something. So stating an observation is not saying, "Well, you're doing this," because when we do this and we say you, we're pushing that person so they feel backed away into a corner. I feel defensive when someone keeps going, pointing at me and doing this and saying, you. So in a gentle way, if we say, hey, how you doing? We leave some pause, some time, and then we say, okay, you know what? I noticed that usually, you know, usually you're really up and at it and ready to go. And I notice you're drinking a ton of coffee. And, is that because maybe you're feeling more tired? Or are you doing okay? So sometimes we can state an observation. I noticed that. I noticed that, like you're always into fashion. And lately, the past couple days, it's like you've been wearing the same clothes. Is everything okay? So we can use an observation to state what we're seeing, and what that does is it's a little more objective. So it's like, I noticed this. It's not saying you shouldn't do this. It's not saying ew or judging. It's just saying I notice. Then from there we can also express concern. So when expressing concern, we again want to use I statements. So you know, I'm kind of concerned that, maybe you're not sleeping that well, or I'm concerned that, I know that you've mentioned in the past you've struggled with depression. I noticed that, there's some things going on that seem a little off, and, I am concerned that you're doing okay. How are you doing? So when we express concern, try to be genuine with it. Try to put it a little gently. I am a more direct person. However, there's definitely times where I need to soften up and see how the person's responding. If you notice the person's tensing up a little bit, or you notice that person's even maybe physically taking something, their body away from you a little bit, then just maybe see if you can give it some pause to reset it a little bit, and then maybe speak a little bit more gently or lower your voice, your tone. See what's receptive to the person if you're able to. So we want to check in. We would love to listen and state an observation. Of course, we want to express concern in a genuine way and use I statements. And also, this is what comes back into the allow space. So if a person is really struggling, it can take time for them to express it. They may be, like I've had people do that verbally, but also physically. I've had conversations where I said, hey, we're going to check in today. And in an elementary or a high school setting, I remember there was an individual, and she locked herself in the bathroom stall, and she waited 10 minutes into the appointment, and then she came out and she's like, I just needed to kind of figure out what I was going to say. So sometimes like we do have to allow space, because the individual might be communicating something that maybe they've never said out loud. Maybe they're scared of the consequences of saying something out loud. And maybe they want to think out, or they're just struggling so much that they can't put it in words yet. So really, when we are having these conversations, if someone is seeming like something's a little off, please try to allow for space. That includes like listening, but also just being aware that, silence can feel uncomfortable, but it's okay, because what can bloom from silence can really help the person feel safe and comfortable and respected when we're not rushing them. And then also, the last step that we can do is we can offer support. One of the things, if you've attended any of the other trainings in the depression and anxiety series, you've probably heard me say the word realistic a million times, especially in the SMART documentation training. Why realistic is so important is because what it does is it helps the individual have expectations that are real. And it also helps them feel like they have resources that are responding to them, that are listening, that they can reach out to. So what happens is if you tell an individual, hey, I'm always going to be there for you, call me day or night, don't do that. That's not really supportive. Why? Because chances are you're not going to be there day or night, and you shouldn't be. Which we will talk about safety planning, but offer realistic support. So, hey, during these hours, I'm available. Just want to throw it out there. There's 988. You can call, you can chat on the web, or you can text. And sometimes that's a good support. One of the things I like to remind people about 988 is that there was kind of this stigma when it was referred to as the National Suicide Hotline, because really what happens is you can call that, and you don't have to feel suicidal. So maybe you're feeling some type of crisis or some kind of acute anxiety or depressive symptoms. You can get support from that. You don't have to meet the qualifications that you have to be suicidal to utilize it. So 988 is a wonderful support that we can say, hey, I know I'm not going to always be available to you, and outside of sessions and outside of business hours, I'm not always there. Even during business hours, sometimes I'm with other clients. However, there's this resource and it's really good and it's free. Sometimes just offering that in a realistic way is just a really good way to support the individual. Just throwing it out there. And if they want to pick it up, that's great. If not, that's okay too. When we are offering support, if something is off with an individual, please also just have in the back of your head, the individual may refuse at first. So a lot of times people make these kind of like placating statements like, no, I'm fine. I don't need that. Like, that's too much. Or I'm fine. You know me. Like, I get through everything. So don't be super bought into the fact that I'm going to throw out a resource and this person's going to swoop it up. Or I'm going to offer the individual another session or a sooner session and the individual is going to swoop it up. Maybe they're not going to accept it or take advantage of it, but the fact that you offered support shows that you care. And the fact that you offer realistic support shows even more that you care, because you're not saying I'm going to do it all and without me, you're going to fail. You're saying, hey, like, there's a lot of resources out there and I encourage you to utilize what speaks to you. So we're going to move into some definitions. Some definitions that we have here are suicidal ideation. So the term suicidal ideation can refer to thinking about, considering, or planning suicide. Ideation is all about thinking about. When we do reference suicidal ideation, intent and plan are not implied. So a lot of times if you are documenting suicidal ideation, you will include, the patient has verbalized suicide ideation without intent and or plan. So a lot of times on the end of that, you may include or in the next sentence about intent and plan. It certainly can mean that the individual is planning or considering or has intent. However, it is not implied in the statement itself or the term itself of suicidal ideation. So just wanted to make that clear and distinct. A suicide attempt is a non-fatal, self-directed, potentially dangerous or injurious behavior with intent to die as a result of the behavior. So an actual suicide attempt, there is intent that that was there. So the individual might not die, in the injury. Somebody may have had a suicide attempt that was, I hate the term successful, but that means that they were able to die as a result of the act, but a suicide attempt may not result in injury. A lot of times people may try to overdose or maybe even a cut that wasn't deep enough to do what their intent was to die. So any suicide attempt includes intent that is present. It doesn't necessarily mean that the person was injured even because of it. Suicide is defined as the death that is caused by self-directed injurious behavior with intent to die as a result of the behavior. And we will go over the tip sheet very briefly in the end, so that we'll talk directly. It has directly what to do about some of these things that happen, kind of how to respond in a super short, concise way. So, warning signs of risk. I'm sure a lot of you have heard these before. Maybe there's a couple on here though you haven't, so I'll go over them very quickly. But withdrawing from friends or loved ones, giving away important items, dangerous, risky behavior, concerning statements. So people would be better off without me. Nothing really matters. Even I wish I was dead. Things of that nature can really, you just kind of like, oh, something's off, something's not right. Like, this is the warning signals go off. No goals for the futures or future plans. Maybe they can't think of reasons to live, and access to the means. So sometimes people buy a gun or they have access to a gun. They may be stockpiling pills or have pills that are, more heavy narcotics, and they have access to that. previous suicide attempts can be an indicator. If the person is, combined with other factors, making certain statements, you notice a bunch of different things going on, and they've also had some previous attempts. Legal and criminal problems, sometimes that can be a warning sign of risk that the person might be feeling down in a way, or that they're unable to escape something. Impulsive tendencies is huge. I've worked with a lot of survivors actually of suicide attempts, and I will say what really stood out to me was that a lot of the individuals that have survived suicide attempts have said, and I was actually kind of astounded to hear how many people have said this term, but I loved my family and friends, and it was just so in the moment. It wasn't anything about them, nobody could have done anything, and really just that theme of impulsivity. So that's why when we think about like the access to the means, that's kind of paired with impulsive tendencies. If the person already has impulsive tendencies, and then you notice a lot of these other things, that could be definitely a warning sign of some risk. Also, if the individual has stigma of help-seeking behavior, that could be something, again, that we would want to open the conversation about, maybe leave some resources around. And I always like to pair, 988 is free, it's confidential. They're not going to call 911 on you unless you are going to kill yourself, right then and there. They're not going to do that. And there's very few cases that they do. But it's really important to know that you have this resource. If the person's talking about suicide, even if they're just joking about it, that can definitely be a sign. Extreme mood swings could be, hopelessness, preoccupation with death, dying, or violence, saying goodbye to others. Any dramatic changes in normal routine, especially eating and sleeping, can be big warning signs. Maybe the individual has not slept for a long time, or maybe they're just sleeping all day and night. And eating too. Those things, being aware of those changes, that can indicate risk, as well as reckless use of drugs and alcohol. I just don't care about what's going on with my body and what I'm using. So some phrases that to try can be, please don't hurt or kill yourself. So sometimes people say, please don't hurt. Sometimes people say, please don't kill. But please don't do this to yourself. I don't want you to die. I would miss you. My life would be less full without you. And the last one can kind of seem like a little weird if we're saying it to a client. But I think, like I look forward to seeing you. And, these sessions are something that I think are a beautiful thing. And it's just awesome to see you changing and trying, and despite challenges, really working through it. So just encouraging them. It can be a wonderful way, if we are noticing some signs, to try to just let them know that we value them. So we want to appropriately respond, of course, when individuals are communicating this. So if individuals are communicating some ideation about suicide, what we would want to do is we would want to support them in identifying some plans for the future, as well as some reasons for living. What this does is it can help the person look forward. And an individual that is really close to committing suicide may have difficulty making plans for the future and naming any reasons for living. So the biggest thing that we want to do, though, is we want to secure their safety. So what this means is, again, if someone has suicidal ideation, doesn't mean that they have plan or intent, but we want to kind of monitor this, and we want to say, are you safe right now at this time? If the individual is not able to, then what we would want to do is we would want to call for a crisis evaluation and remain with that person. Maybe we call 911 because we want to get that person help. If they say not right at this time, we say, okay, you know what? Let's review your safety plan. We can review the individual safety plan with them. And then what we can do is check in again. Are you feeling safe now? We're able to review some triggers. It looks like you've had multiple triggers since last night that make you feel unsafe. Do you feel a little better? I feel a little better. Okay, so let's talk about some plans that you have for the future. All right, so you got some good things to look forward to. So why don't we talk about some reasons that you have for living? Okay, we did that. Now, do you feel a little better? Do you feel safer in this moment? Right now at this time, can you tell me that you do feel safe in this moment and you're not going to do anything to hurt yourself? And then if the individual is able to secure their safety, you would definitely want to document that. You would want to make sure that they have a copy of their safety plan, they're aware of 988 and their resources. And then, you don't need to call 911 or take that person to the hospital or anything like that. Certainly, if the individual is expressing suicidal ideation at any time, you can encourage a crisis evaluation, especially if the person's open and willing to it. However, you don't want to force that upon someone. Sometimes an individual may have some expressions of suicidal ideation, and that doesn't mean necessarily we need to panic and call 911. Maybe what we can do is we can review some of these things. We can allow space and time to talk about what's going on and continue to check in. The ideal situation is that individual is able to secure their safety, give you reasons for living, plans for the future, have a safety plan in hand when they're leaving your office or when they're leaving their interaction with you, and that you're able to document that you were able to follow the appropriate steps so that person really felt supported. So suicidal ideation, there can be a variety of ways to react. And we'll also look at the tip sheet there just for kind of a quick guide. But essentially what we want to do is when someone is expressing this, we want to take some steps, not like pull the fire drill and panic, but we want to take some steps to remind them of maybe some of the things that they have to look forward to or some reasons for living, and then like help them move forward a little bit. If they're not able to, then that's also fine. We just want to do what is the most important, which is secure that person's safety, which even if it makes them upset, we definitely want to encourage a crisis eval, whether that be take them to the hospital and they get a crisis evaluation there. So there's some agencies that can come in and just do a crisis evaluation on the spot. And in some instances, certainly we may have to call 911 in certain settings because we don't have those resources at our fingertips, or maybe anyone, in our facility that is able to do that. So suicidal ideation, there can be a variety of ways to appropriately respond, but really, trusting your gut. If you're really scared about this, then there's a reason for it, and try to open the conversation. And we may use some of those terms, I don't want you to die. Check in with the person and kind of see how they're doing. A suicide attempt, what we need to do if a person has communicated that they've had a suicide attempt, we need to secure their safety and we need to document. What we need to do is we need to call 911 or whatever appropriate service. I say 911 because the only other instance I could think of is when I was on a military base. It was actually the first client I saw in that position. They just reported, the first client I saw, they just reported that they had an almost lethal attempt of killing themselves. So what ended up happening was I had to call, you don't call 911 in those situations, you call the equivalent of 911 on base, and they were able to escort that person to the behavioral health center for a full eval. But in an instance where someone has reported a suicide attempt, we do want to call 911 or encourage a crisis eval. Maybe they're, I'm never going to do that again or whatever. Okay, but you still need to get evaluated. So, I don't necessarily want to call 911 if you're willing to do this. So like, can we have someone come in and evaluate you, or, can I escort you to the hospital, or have someone escort you to the hospital? We don't want to leave the individual alone because they could feel, sometimes people may feel guilty or may feel like, oh, I can't even do this right, or I should just try again. So when someone has communicated that they have attempted suicide, we don't want to leave the individual alone. We want to make sure they get to the appropriate resource. So that is very, very important. If someone does report that, we want to make sure that they are safe. And sometimes people minimize it. They may say, well, I took, 7 Tylenol and that didn't really do anything. Obviously, I'm still here. We would still want to make sure that person's safe. We would still want them to go to the hospital or for a medical eval, because obviously something could be in their system, something could be off, and they don't even know it. And maybe they don't wake up the next day. So we just want to make sure that we appropriately respond when someone communicates that. All right, so moving on. At this time, just a little tip, when documenting that a client is safe, so we say, patient denies suicidal ideation at this time, use at this time. Why? Because it makes more sense, especially in the legal term. So it shows the limitations of our care. So obviously, like if you're like, yeah, that person denied suicidal ideation, and then later they go home and they kill themselves. Well, it looks like, well, what was, you didn't see anything. But if you say, hey, client denies suicidal ideation at this time, was able to identify plans for the future, including, family reunion next week. Now all of a sudden it's making sense. Like when this person was in front of me, when I was evaluating this person or assessing this person, at this time they were safe. So really we can only work with the individual's current state. Impulsivity plays in with suicidal ideation, so it can happen at any time, but we definitely want to kind of cover ourselves legally, and using at this time is a wonderful way to do that when you are documenting. So your actions matter. When you are having these kind of conversations, pay attention to your own body language. Maintain eye contact with the individual. You can sometimes people tilt their head slightly, so it seems like sometimes if you're straight on with someone, it can seem a little intimidating. So sometimes like turning slightly or tilting your head slightly makes it seem a little softer, warmer. If you're texting or typing and someone expresses something, you can use emojis. I actually took a class years ago about certain emojis that can be helpful when individuals are expressing difficult feelings, and like even like the heart emoji with like a little band-aid kind of thing over it, or I care about you. So there's different things that you can use if you are doing that. Of course, if you are typing or texting, you would want to get that person on the phone or in front of you to be able to really assess what's going on. But you can use appropriate emojis to express concern as well. We want to also ask ourselves, just checking in with ourselves and being real, what is my tone saying? Does it sound like I actually care? And am I allowing for pause for this person to speak? So protective factors are another great thing that people have. So sometimes what happens is people have expressed suicidal ideation. However, they have these protective factors that they'll never do it. So that's a great thing. So one of the most common ones that we can think of is religion. A lot of times, I can't tell you how many times I've heard it, I would be better off, Dad. I'd like to die. It'd be great because I'm in so much pain or whatever. But I believe in God and I don't want to go to hell. I've heard that so many times. So like that's a good thing in these situations, these protective factors, but there's individual protective factors, which are certainly coping skills, reasons for living, like meaningful reasons for living, as well as identification with cultural background. And relationship protective factors can be support from partners, friends, family, as well as a connection with community. Community is also engagement, so like school, community, social interactions, events, and then also access to high quality behavioral health care, physical health care that is consistent is a huge protective factor. Another societal protective factor can be if there's a restriction of lethal access to means for people that might be thinking that way. So for example, maybe this individual has had multiple attempts with prescription medications. Maybe the doctor's not prescribing narcotics now for certain things, just to restrict some access to more lethal ways of killing themselves. And then also there's cultural, religious, and some ethical oppositions to suicide that can really help people say, even if I feel that way, I'm not going to act on it. So if you do believe someone is suicidal, you can listen, you can support, but offer 988. So 988 offers call, text, and website chat. In scenarios that you cannot secure safety, call 911. It can feel weird because you're like, I want to support that person. That person might be really angry with me, but we really need to secure that person's safety. If you're not sure on what to do, if you're like, I don't know, like if I should call 911, consult. So it's better safe than sorry. It does not always apply in certain situations. So if you're not sure, consult with a colleague, a manager, another mental health professional, or another professional in general, medical professional. It can be really important to do that. And I would say, make sure you document that. So if you consult with someone, document it. I've consulted with a colleague or with this person, and we agreed that at this time this person is safe. This person has agreed to utilize 9888 and was given a list of local resources if they do feel suicidal again, or they feel suicidal. If we're not sure, try to keep the individual in sight. And even when you're consulting, maybe you like leave them in a room alone and then you can step out quick and do a consult. But make sure that person is safe if you're really not sure. And you've heard me say this probably a million times as well. If you did not document it, it didn't happen. So the individual cannot secure their safety, communicate reasons for living, plans for the future, call 911 or ask them if they're willing to submit to a crisis eval. You can call some agencies in. Sometimes they'll just do a crisis eval. Sometimes there'll be someone that can escort them to the hospital. But really, if you didn't document it, it didn't happen. So we want to make sure we follow the necessary steps, but also that you document it appropriately as well. So quick tips for working with individuals that may be at risk for suicide is that we do want to be direct. So sometimes we have this thought like, that if we say it out loud, then it might happen, but really we want to communicate our concerns directly. Don't circle around it. Try to rehearse it if you need to ensure that there's not misunderstandings. Because sometimes like saying, do you want to kill yourself or do you want to harm yourself? Those are different things, which we will get to very shortly. But rehearsing difficult conversations really can ensure that you feel prepared. It can allow you to adjust body image, body language, but also it can ensure that there's not misunderstandings. So be direct. I'm really concerned that you're going to kill yourself because of, all of these things that are going on with you. And I don't want that to happen. I care about you. We can express concern. Thinking about how we would want someone to express concern if we were feeling that way. So just use techniques that are genuine to you. I didn't list all these techniques that we could use because it's really what speaks to you in a way that you can be genuine. So just make sure your tone, your actions, your body language, your words align with caring and what's genuine to you. And then we want to be realistic. Again, we mentioned this earlier, but don't promise you're always going to be there for the person. You're not going to. So offer resources that are helpful and create a safety plan, giving it to the client and keeping a copy for yourself if you're able to. Even if it's like just generally, in a medical record or something, keep a copy for yourself because that can be helpful sometimes. If, oh, I lost it. Okay, well, I have it. I'll make another copy for you. But be realistic with it and then document everything. With high-risk clients, it's so important to show that we've taken the most appropriate steps. So we need to write notes so that we can ensure that we're acting in the best course of action for them. Important distinction, and I'm moving along quickly, so we do have time for questions at the end, but harm and kill are not the same words, so we may, again, feel like we don't want to put the idea in their head. However, research does show that being direct and clear about your concern, it really shows that you're acting in the most supportive and ethical way. So use a language that your client understands, and if you're concerned that this person is going to kill themselves, then say kill. It can feel awkward, but it can be a very important distinction. Also, another special consideration is you don't want to just use this training and just say, oh, I'm gonna ask everyone if they're suicidal before, if I'm a little concerned. Asking if someone is suicidal can have consequences, especially true for children. So a child may question if a parent is trusting them, is loving them. Why does my parent think that I'm going to kill them or I'm going to kill myself? Like, do they think I'm a bad kid? So sometimes what happens is adult psychologists or psychiatrists or even medical professionals may say, well, are you thinking about killing yourself? Are you suicidal? And a kid, first of all, may not really know what suicidal means. And also they may turn it in on themselves and internalize and say, well, why are they asking me this? So we want to be considerate in when and how we're asking. We want to see those red flags and we want to put in a language that people can understand. And I would say if you're not sure if you want to directly ask that question yet, that's okay. There's some statements that you can gather, maybe don't ask the child right out. Maybe ask them their reasons for living, plans for the future, like ask them about some of those kind of things. What makes you happy? And then, if you're still feeling like this is something I really need to ask, then ask it. But sometimes like we just want to just be aware that like we shouldn't just blanket this and ask everyone and expect that it doesn't have any kind of consequences. Timing is huge. Obviously, if you're like, there's like all the warning signs, but I'll wait till next session. Please, in the ultimate dilemma, you know, obviously you would rather have someone alive and angry at you than upset with you, or happy with you and not there anymore. So in many real life scenarios, survivors say, you know, I'm happy that someone reached out. I'm happy that someone offered the support or reminded me of this resource. So some quick myths and stereotypes. A myth would be that discussing suicide will raise the likelihood of it. That's not true. It can offer a different perspective for the individual. It can remind the individual of their resources, and it can provide crucial support. So if we are, you know, concerned about this, you can initiate the discussion, and you can do it in a kind way. Also, sometimes people say, well, there's not a lot that people can do. If they want to do it, they're going to do it. To some extent, that may be true. However, there are steps that we can take. So if we see these warning signs, if we begin restricting access to lethal means, like firearms, things like that, it can be a lifesaver for some people because it's not right there in front of them. And again, that impulsivity a lot of times leads to the suicide attempt, or that's what's in the moment. So if we can reduce the lethal factors around the individual, then really we can save lives. And then also people who take their own lives are weak or selfish. Totally, totally not true. People that die by suicide, they often undergo very, very intense kind of emotional pain. So it can be challenging for them to even think about other ways out or envision how things could be different. So there's so many different factors when a person commits suicide that it can be super intricate, and it's definitely not something that's just, oh, this person's this way. There's so many amazing people that unfortunately have lost their life to suicide, and there's just a lot of factors that can go into that. So safety planning, we're not going to dive into hugely. We're just going to touch on this. This is something that certainly leave in the course evaluations if you'd like to expand on. I think it's a wonderful, super awesome topic, and you actually can use safety planning in a variety of settings. So I'm going to throw it out there. The free one is on Therapist Aid. So therapistaid.com has a free safety plan. It doesn't have all the bells and whistles, but it has some, you know, a template that you can use or just use for motivation. So there's lots of different free templates out there, but you can utilize at any time. So you can create one at the beginning of care. You don't have to wait till a person's suicidal or anything like that, or even a person that has no history of suicide ideation. You can create a safety plan for other things. So maybe a safety plan because when they get angry, they punch something. You can create a safety plan to let the person know, these are my triggers, my feelings, my behaviors, and these are some of the coping skills that I can utilize. And then here's some support. It is important when you are writing out your supports that you get super specific. So write the name, write the contact of the individual, call, text, whatever. Because you don't want the person saying, oh yeah, I'll call my aunt. Okay, well, would you call or text her? She kind of prefers text, but I wouldn't really call her that much. I'll just list her on here. No. If it's not realistic, like, we want to make this realistic. And then it's super important to have local resources. So 988 should be on everyone's safety plan, just in case. But local emergency numbers, any mental health providers, anything like that in the community that the individual could reach out to, could be spiritual advisors even. But anyone that someone could reach out to can be super important to have on it. Why? Because when the individual is feeling triggered, they can pull it out of their pocket, their briefcase, their purse, wherever, the backpack, and they can look at it. Also, sometimes individuals take a snapshot of it on their phone, and then they can refer to that as needed. And I would say, again, make copies, make copies, because a lot of times individuals say, oh, I lost that, or you may be in session and say, you know what, like, let's just do a refresher. Your safety plan. Is there anything that we can update on this? It sounds like that's a trigger that we don't have in your safety plan. Like, why don't we write that down and let's maybe come up with a couple more coping skills for that. So update it as needed, but a safety plan can be a lifesaver because it reminds the person of the things that are around them to support them. 988 Lifeline, super, super, super important. And I know that we don't have that much time, so I just really quickly would like to direct your attention to the tip sheet. So this was sent to everyone today. So this is just a really quick tip sheet that I wanted to include. What we do is we talk about awareness, so some signs, and this is just a little bit more concise because it's easier. You can print this out. I used to have a clipboard that opened, so sometimes like you can just slide that in there or in your briefcase. So some signs that someone might be considering or planning suicide, and and then of course the response. So if a person comes to you, they say, I have a history of suicidal ideation, or I have a history of suicide attempts, or anything like that, we just can monitor. When we start to see red flags, we want to express our concern using those I statements and offer support. If they are reporting ideation, we want to open the conversation, assess the situation, and refer for crisis eval if it's appropriate. And then also, if they do report a plan or attempt, we want to contact 911. We want to get that crisis eval resource there or escort them to the hospital. So I also have 10 quick tips there that we can use for individuals to feel secure about talking, and how we can kind of manage individuals that might be a little bit more difficult to work with. So there's just guiding with compassion, seeking support together, but also in the top 10 of this discussion here is caring for yourself. So we also need to remember that the helpers need help. So we need to prioritize our own well-being too, and that falls into the realistic conversations. We want to offer support in a realistic way. We don't want to say we're there all the time, but we do need to care for ourselves so that we can feel re-energized and we can work with these populations. So also included on the tip sheet is a quick resources. So we have the national hotline. We have the Veterans Crisis Line. Veterans are at more of a risk for suicidal ideation. We have the SAMHSA, the Substance Abuse Treatment Referral Hotline. Also, there's another crisis text line that if you just want to text, you can text talk to 741-741. And then also therapistaid.com has a wonderful resource, all different mental health resources for free that you can print out, you can share, and they do have that safety plan template. So that's just really quick on the tip sheet, what we have there. Let's see, I know that we have 5 minutes, so we're actually, the real life scenarios, we're going to skip over just really quickly and just talk briefly about how we can avoid burnout. Obviously, working with individuals that are a little bit more challenging, whether it be, they're managing different mental health symptoms or they're feeling suicidal, we can really start to escalate towards burnout. So one of the big things is exercise, diet, hydration. Staying hydrated flushes all those extra stress chemicals that are building up out of your system. So just flush them out. Mindfulness and good deeds. A good deed can help change our perspective a little bit sometimes, and can help us just feel good. Deep breathing, meditation can be a very wonderful way as well to avoid burnout. And then creative expression and just making plans. So maybe you have, I have a big caseload. I have a lot of clients that need to be seen, a lot of things going on. However, I know at the end of the week, I have this fall festival that I'm going to, and I'm really, really looking forward to it. So that can keep me kind of going and feeling motivated during times that maybe I feel like a little burnt out. All right, so I know we blew through a lot of information. It was a lot to talk about. Thank you so much for letting me talk about it. We're gonna have a little bit of room for questions and answers, but I wanted to ask, Victoria, is there any, would you like to talk about this opportunity that's coming up very shortly?
Sure. Thank you, Jessica. A lot of great information shared today and such an important topic. So this does conclude our 3-part webinar series with Jessica, but we do have a new 2-part aging series coming up that we wanted to share. The first session here is planned for Thursday, October 24th. It's called Understanding Home and Community-Based Services. So we welcome you to register and join that series, and the link and QR code can be found here on this flyer. So thanks again, Jessica. You've been great. And now I guess we can probably open it up for some questions and answers.
All right, wonderful. I know we went over things very quickly, so I appreciate everyone's patience with that. I think we covered a lot of important topics. Let's see, are there any questions in the chat? No? Okay, but so anyone, feel free, it's 3 minutes. So if everyone has 3 minutes that you'd like to take some deep breaths and grab a drink, then feel free to at this time. And I think we have a question too for the registration for the aging series, Kelly or Victoria.
Yes, I can include the flyer with the email that follows this training. It'll include the evaluation link as well. So I will definitely include that flyer.
Wonderful. All right, thank you everyone for your time. And I'll be on here if there's any questions or anything like that.